Welcome to the PBRN webinar on strategies to support cooperation of multiple organizations' institutional review boards. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Gabriela Neves-Adi, Director of the AHRQ PBRN Resource Center, will introduce today's presenters. We will then hear from our presenters about their experiences working with multiple IRBs. We will have a brief question and answer session after the first three presentations, and we will have a second question and answer session after the fourth and final presentation. At the end of the webinar, I will explain how to obtain CME credit for participation in this webinar. Please note that after today's webinar, a copy of the presentation slides will be emailed to all webinar participants. I will now explain how to submit a question to today's presenters. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A sessions, as time allows, your question will be read aloud and our presenters will respond. And I will now turn the presentation over to Dr. Neves-Adi to introduce today's presenters.
Thank you, Kristen. Welcome, everyone, to the webinar. My name is Gabriela Neves-Adi, and as Kristen said, I'm the AHRQ PBRN Resource Center Director here at Abt Associates. And I would like to introduce our four presenters for our webinar today. Our first presenter is Jeanette Daly. Dr. Daly is the Associate Director of the Iowa Research Network. She's also the Associate Research Scientist at the University of Iowa Carver College of Medicine. In this role, she's authored over 100 publications focused on elder abuse, legislation related to elder abuse, colorectal cancer screening, fecal immunochemical testing, and other nursing-related research. Our second presenter is Tabria Weiner. Tabria Weiner is a primary care PBRN coordinator with the Colorado Health Outcomes Program and the Shared Network of Collaborative Ambulatory Practices and Partners, or SNOCAP. She works with medical practices to conduct evidence-based research to improve health care for their patients and provide support to maintain collaboration among academic and community partners. Our third presenter is LeAnn Michaels, who is the manager of the Oregon Rural Practice-Based Research Network. As ORPRN manager, she works with researchers to complete grant proposals, manages the ORPRN team, and oversees network operations. She also functions as the research coordinator for the Meta Network Learning and Research Center, or Meta-LARC, where she works on data management, IRB approvals, and project development. And finally, our fourth presenter is Amanda Ross. Amanda Ross is the Administrative Director of the PBRN Shared Resource at Case Western Reserve University, and the Collaborative Ohio Inquiry Network, or COIN. Amanda Ross has been involved in the administration of translational research for the last 9 years. She's comfortable working with both biomedical and behavioral institutional review boards and enjoys facilitating multidisciplinary collaborations locally and statewide. I will now turn it over to Jeanette Daly, who will discuss research collaboration with the University of Iowa. So I don't see my screen.
Jeanette, if you're able to pull up your slides, you can run them from your desktop, or we can show them for you. What would you prefer? Oh, there they are.
Can you see them? Okay. All right. I'm sorry. I didn't realize that.
No problem.
Okay.
That looks great.
Okay, so I'm going to talk in general about research collaboration and kind of specifically with the University of Iowa. And I have a quote here from The Hobbit, just to make you think about some things with collaborating with offices or PBRN
members who are not affiliated with an academic center, you know, they want to know about the risks for their practice and for their patients who might be their subjects, what any out-of-pocket expenses might be for themselves, will they be reimbursed for participating, you know, what they're going to get out of it. So all human subjects research conducted at the University of Iowa or under its auspices must be reviewed and approved by an IRB prior to the start of the research, and that includes cooperative research. So the U.S. Department of Health and Human Services and the Food and Drug Administration do provide federal regulations that allow for cooperative research projects which involve more than one institution, as multiple IRB applications would be redundant. So minimally, cooperative research involves one practice-based research network at an academic center with multiple family physician offices who may or may not have their own IRB. So later, LeAnn will be talking about multiple PBRNs working together with many physician offices. So community-based research often involves collaboration with non-University of Iowa entities whom we call community partners. And these community partners generally fall into two groups, those who have their own IRBs and those who do not. So the purpose of our community-based research here at Iowa is to facilitate community-based research by providing mechanisms to extend UI IRB oversight to community partners. So collaborative research is considered community-based research when the project meets the federal definition of research, and that is a systematic investigation including research development, testing, and evaluation designed to develop or contribute to generalizable knowledge. It also is that the research participants are human subjects, and that the community partners are engaged in the research, and that means the office staff are actively obtaining data or obtaining informed consent of the research subjects, and that the project is no more than minimal or moderate risk. And risk is defined as the probability of harm or injury occurring as a result of participation, and both the probability and magnitude may vary from minimal to significant. So the UI IRB oversight is extended to cover a community partner through an individual investigator agreement. And we have a community partner checklist here at Iowa that would include a letter of agreement, human subjects protection training, Health Insurance Portability and Accountability Act, a HIPAA letter, and FERPA, which is the Family Educational Rights and Privacy Act, which is the federal law that protects privacy of student education records. And then we have different ways that we do it if the community partner has a federal-wide assurance or FWA, or if it does not have a federal-wide assurance. So the letter of agreement confirms that the community partner is committed to participating in the research, that the community partner understands their role in the research. And it has to be clear that the community partner, not only the physician, but the staff that are going to participate in the research, that they all understand their roles. That a collaborating site will allow conduct of the research on their premises and are using their information and or resources. Organizations serving as community partners affirm that they will maintain copies of all professional licenses and verification of background checks on all staff members. And for independent community partners, letters of agreement are required from each organization on whose premises the research will be conducted and or whose resources or information will be accessed. Individuals serving as community partners are asked to provide a copy of their current CV or resume to the principal investigator. And then for human subjects protection training, all community partner staff deemed to be engaged in research are required to complete human subjects protection training. And here at the Iowa Research Network, we keep a copy of everyone's certificate and have a database of delegates when we submit IRB projects. We have people take the online course certification in human subjects protections, the CITI course. So for HIPAA, if a community-based research project will access protected health information, the privacy officer of the organization where the protected health information will be collected will need to provide written authorization for that. I've put on a sample of IRB authorization agreement here, and it just, you put the two organizations that are agreeing to work together, say the University of Iowa, you have Iowa's IRB registration number and Iowa's federal-wide assurance number, and this particular form would be for an officer, another agency that has their own FWA number, and then you add the protocol and the signing officials sign it. So the IRB seeding process gives control of IRB review, approval, and oversight of human subjects research to another IRB. It allows one IRB to rely on the other, hopefully reduces duplication of effort, and increases efficiency by designating a single IRB. So now on to the polling questions. And will you put my polling question up, or should I just read it?
Yeah, the poll is now open. We've just opened it. So we're leaving it open for about 30 seconds for people to vote. And so the poll is still in progress. Does the IRB at your institution have seeding forms? Yes, no, or I don't know.
And I'm sorry, I can't see that.
Okay, we'll close the poll now, and we can read the results out loud. So we're gonna go ahead and close the poll, and the results should pop up. So we have 29% of people said yes, the IRB at their institution does have seeding forms. 20% said no, and 52% said that actually they don't know.
Okay, so I'd just like to say here at Iowa, I found that we do not have seeding forms, and that to seed for the project that LeAnn's going to talk about, or Tabria, we had to give everything to our IRB through emails, no official application on the web. So thank you, everyone.
Great. Thank you so much, Jeanette. Now we're going to hear from Tabria Weiner, who will discuss the Colorado Multiple Institution Review Board and the Implementing Network Self-Management Support Tools through Engaging Patient and Practices study.
Great, so we can see your slides, Tabria. You can go ahead, and if you're on mute, you can go ahead and unmute yourself.
Okay, can you see my slides now?
Yes, they look great.
Perfect. All right, well, thank you all so much for being here today, and thank you for the introduction. As it was mentioned, I'm going to be talking about the various types of IRB cooperation in support of practice-based research, specifically working with the IRB here in Colorado, or COMERB, and then the INSTEP study that Jeanette mentioned, and I think LeAnn will also bring up as well. So I'm going to start out with just a little bit of background about COMERB, and it stands for the Colorado Multiple Institutional Review Board, and it actually has 5 sites that it oversees. The first of which is the University of Colorado, Denver, both the Anschutz and the downtown campus, so our medical campus and our predominantly education campus. A very large hospital system here in Colorado, the Denver Health and Hospital Authority. Another large hospital system, the University of Colorado Hospital. And then the Veterans Administration Hospital, and then the Children's Hospital Colorado. And so what that means is that having all of these under one IRB, they all submit to the same one. Research can be done in each of the different places or using patients or subjects from each of the different institutions. And all they have to do is fill out, I think at most it's just a couple extra pieces of paper, but it still helps to streamline the process and to encourage collaboration among these 5 institutions. So COMRB is comprised of 5 IRB panels. 4 of them, all of them review the protocol for the UCD and its affiliates, the other 4 that I mentioned. But 4 of them are specifically focused on general protocols that are submitted as well as biomedical protocols. And then 1 of them focuses more on the social and behavioral protocols. And the nice thing about all 5 of these IRB panels is that they can do both adult and pediatric studies, so you don't have to submit it through a different IRB or go through a different process. You can just submit it to COMRB if you wanted to do pediatric studies. And as most IRBs, the purpose of them is to just ensure the protection of subjects, make sure that everything is HIPAA compliant and no personal health information is being shared. So conducting research, practice-based research in Colorado, as it was mentioned, I'm part of SNOCAP. I'm the coordinator for SNOCAP. And SNOCAP is actually an umbrella organization for all of the practice-based research networks here in Colorado. And there are a total of 5. 4 of them are primary care, and 1 of them is a public health PBRN. And the 4 primary care practice-based research networks, the first one is CareNet, or the Colorado Research Network, which serves urban, underserved populations here in the Denver metro area. Then there's Bighorn, which is actually, it's throughout Colorado, and it's predominantly private practices. And then there's High Plains Research Network, which if you draw a line down the middle of Colorado and everything east, every primary care practice east is part of High Plains. And then there's the pediatric PBRN, and that's COCONET, the Colorado Children's Outcomes Network. And as I mentioned, there's the public health PBRN, which is structured a little differently as it focuses more on the health departments here in Colorado rather than primary care practices. And so all the SNOCAP practices are the oversight for them, the directors for them, live at the Department of Family Medicine here at the Anschutz campus. And as I mentioned, they're located throughout the state. So what that means is that they may or may not have a formal IRB affiliation. Some of our practices are part of larger hospital systems or larger systems, and then some of them don't have any type of IRB affiliation whatsoever. And the majority of our practices are not research practices, and I have here, they do research on the side. And you know what that means is some of the clinicians there are also part of the university system, and when a study comes along, they want to implement it in a practice, but they don't have the coordination or support within the practice to do that. And so what SNOCAP did back in 2007 is, in order to do research throughout Colorado, excuse me, and have IRBs or have the security of an IRB in place, is they created a contract with the Colorado Central Area Health Education Center, or CCAHEC. And what CCAHEC did is they provided a federal-wide assurance number on behalf of all of the unaffiliated practices. And they did that by providing all of these practices the human subjects training required by COMRB. And so they actually created a curriculum, and they go out to the practices and they train members of the practice to meet the guidelines for COMRB. And I'm going to go into a little bit more about that. So the specific responsibilities of the CCAHEC is that each practice is required to have a lead clinician and a research coordinator, and they have to complete all of the human subjects training. And then they train all of the clinic staff there on the research study and the specific COMRB policies. And they incorporate the city trainings and just make sure that the COMRB guidelines are met. They also develop the memorandums of understanding with each practice that's participating in a study, and they monitor the conduct of research. So the majority of our studies that we do within practices, the university study team does the recruitment and the consent of subjects, but if that is done in the practices, CCAHEC makes sure that that is done properly. And then they provide COMRB with all of the related data for the specific studies. So the University of Colorado, then, they do the management of the projects. And so in order for a study to be done within one of our practices, it has to come from a principal investigator here at the university. And that's normally where the study team is then housed. And so the study team will go out and conduct the research within the practices. They will consent and recruit if the practice is not doing it. And if whatever study components the practices are specifically doing, if they're providing information to the patient or if they're having them fill out surveys or things like that, the university staff then provides the research support for that. All records of research and IRB is kept at the university, and then they can provide evaluation and quality control of the study as well. So because we have different systems here in Colorado, there's actually a large need for the collaboration with non-affiliated sites. And here at the university, they can do one of two things. And as Jeanette mentioned, there's either ceding to an IRB or serving as the IRB of record. And this is determined on a case-by-case basis. And in order to do that, an MOU or an IAA that Jeanette mentioned earlier has to be in place. Now, even though those are in place, that doesn't take the responsibility off of each institution to protect their subjects. And so it is important that both IRBs, even if an IRB is ceding, they are still involved in the process and they're still aware of what's happening. And then all institutions must comply with the federal regulations. So when COMERB cedes to an outside IRB, a protocol packet has to be submitted here locally to this IRB, stating, there's a little note on there that states that the COMERB director or that the principal investigator wants COMERB to cede to an outside IRB, and that's when the principal investigator and the COMERB director have to meet to determine if that's appropriate. So they go through almost like a checklist to see if the outside IRB meets the same standards that COMERB does. And so with that, the relationship is established, and COMERB has to have the outside IRB's FWA number added to their list of panels. And then the IAA is signed by both institutions, and a copy of that is stored at both places. And then the protocol packet that was submitted to COMERB is then sent to the IRB of record for final approval. And once it goes through that system, COMERB no longer has to approve anything, but they do need to keep copies of all of the documents. And so the final protocol packet that COMERB has to have is the application, an attachment that declares that this is a multi-site study, the protocol, the actual approval letter, any reviewer's comments or any continuing reviews, and then the HIPAA form and the copy of the IAAs. COMERB does, as I mentioned before, COMERB still remains responsible for making sure that everything is compliant with the IRBs, so there's always communication between the two IRBs. Now, when COMERB serves as the IRB of record for multi-site studies, before anything can happen, the principal investigator and the COMERB director, as with the one previously, they have to meet to determine that COMERB can serve as the oversight IRB. And the IAA has to be completed before any research can be conducted. So no recruitment, nothing can be done until the IAAs have been received. It can't even go through the COMERB approval process until all of the IAAs have been included in it. And then all of the other affiliated sites have to add the COMERB panels to its FWA. And COMERB will provide all of the approval letters. So specifically, we have actually done this recently with the InStep study, and it's the study that I'm working on with both Jeanette and LeAnn. And in the InStep study, I'm just going to give a little bit of background of that and then explain the process that we went through to have the other sites seed. So it's implementing network self-management support tools through engaging patient and practices. And it was a multi-site study. We worked with practices in Oregon, Iowa, Wisconsin, and then here in Colorado. And our study design, it was a stepped wedge study design, and the methods that we used were bootcamp translation, and then using the clinic and staff patient activation measure survey with a few questions added on the end related to theory of planned behavior, and then the patient activation measure survey. So because this was a multi-site study, we did do 16 practices across four states, and what that looked like is we had originally planned to just get the IAAs signed from the networks, but it turned out that some of our practices had actually had their own IRB, so they were a part of a large system within their state, and so we had to get more IAAs signed and go through a little bit more work than we had originally anticipated. But we did have 80 clinic and staff participants, and by the end of our project we will have 320 patient participants. So what that looks like here locally is we submitted the application to COMERB stating that we wanted to be the IRB of record. And we wanted to do that in an effort to streamline and speed up the process. So later on when things came up, we just wanted to make sure that we only had to submit it to one place and not to 4 or 5 different IRBs and have to wait to continue our research. We were able to submit it as an expedited review, which means that it is human subjects research, but it is minimal risk and does not involve vulnerable populations, such as pregnant women, children, prisoners, or a population that has mental illness. So we did submit it through COMERB for the reason that all of the data was going to be housed locally here in Colorado on the REDCap database. It was going to be managed by our database manager here in Colorado, and then it's going to be analyzed or cleaned and analyzed by our data analyst here. So that's why we chose to send it all through COMERB. And we went through the IRB record process where the principal investigator, Dr. Don Neese, sat down with our COMERB director, and they decided that yes, we can do this. COMERB can be the IRB of record. We had to get the IAAs, or the IRB authorization agreements, signed by all of the other locations. So we had to send them out, had them sign there. They got sent back to us, and we kept them on file here, and then made copies and sent them out to all of the other IRBs that were participating. We did ask that all of the other IRBs add the COMERB panels to their federal-wide assurance number, and then COMERB would approve the study. And once COMERB approved the study, we were able to conduct it in all of the sites that we had originally submitted, without further discussion or any other hurdles that we had to jump over. And so as we move along in the study, this has made the approval process much easier and happening much faster. When we have submitted amendments or if we have made any changes to the protocol, all we have to do is send it through COMERB. They approve it relatively quickly because it's already in their system as being approved, and then we can continue on with our research, so there's less of a hindrance there. So that is all I have, and if you have any questions, while I would like to say I know a little bit of COMERB, it's pretty much trial and error at this point and what I can and can't do. And so I do have the contact information for COMERB here. And if you want to launch the poll, you can.
Great, thanks. And so the poll is open now. It reads, at your institution, what materials must be provided to cede to another institution's IRB? And you can select all that apply. So we have one form, a full protocol, a short abbreviated protocol, or nothing at all. So we'll leave it open for a little while longer so that more people have a chance to vote. Great, thanks for voting. So I think we'll go ahead and close the poll, and then we are going to share the poll results so you can see them on your screen. So it looks like 33% use one form, have to provide one form to cede to another institution's IRB. 64% of folks have to provide a full protocol. 22% have to provide a short or abbreviated protocol, and 3% have to provide nothing at all.
And I would just like to mention, based on these results, when I was learning about this whole process, I actually spoke with our COMERB representatives and some of the people there, and what is listed here is supported. They said that the majority of institutions require a full protocol still be submitted to the local IRB, which to me sometimes seems like it can be a hindrance because then the process still takes the same amount of time. So I just wanted to say that what I have heard supports that as well.
Terrific. Thank you so much, Tabria. Now we're going to move on to the next presentation. We're going to hear from LeAnn Michaels, who will discuss ceding oversight across multiple IRBs from the perspective of the Oregon Health and Science University Research Integrity Office.
Great, thanks everybody. And can you see my screen?
Yes, we can see your screen and we can hear you very well, thanks.
Okay, great. So I'm going to tell the story about Ceding IRB oversight from the OHSU perspective, Oregon Health and Science University. And our research integrity office is called ORIO, right? O-R-I-O. So I'll tell you guys, we'll talk about what the story has been like here. And then I'm also going to mention a little bit about our P30, of which Jeanette and Tabria participate, and kind of what our vision was for IRB there, and then kind of what the lessons learned along the way have been. Pardon me. So in 2002, I worked at OHSU with the Clinical Outcomes Research Initiative, which is a national endoscopic database, and there were multiple participants across the United States that used our software to contribute data to a national repository. And we did some, and the work I did was recruiting prospective subjects who had had a procedure into, recruiting subjects who'd had a procedure into a prospective research protocol. And there were several academic institutions where I would complete a separate IRB application, but there were some who were unaffiliated, and like at an ambulatory surgery center or an endoscopy center that weren't affiliated with another institution who did not have an FWA. And so at the time, our IRB would use a form called an unaffiliated investigator agreement. And the clinician at the who had agreed to participate on behalf of his or her group would complete a human subjects training and a conflict of interest materials from our institution, and would also then sign this unaffiliated investigator agreement form and submit back to us, which we would then, this was back when everything was on paper, we would submit actually what's called a modification. Now it was called a PRAF here at the time. All of those materials together, plus I would usually like customize a consent form or something like that. And it would take probably from the time the investigator said yes to the time the materials were received and approved by the IRB about 4 to 6 weeks, which I think for paper really wasn't so bad. So that amount of time before we could begin recruiting subjects from their institution. So a few years later, I moved to ORPRA, the Oregon Rural Practice-Based Research Network, and had more opportunities to do research projects with institutions around the state of Oregon that did have their own IRBs. And around this time, too, I think, was when the CTSAs were becoming funded. And our CTSA was collaborating with a health system in the Portland area, Kaiser Permanente, and the two of them, IRBs, had met and looked through their interpretations of the federal regulations together, looked through their meeting cycles, how they handle different protocols, how they determine what's minimal risk, and they agreed that oversight from either IRB would be accepted for the other one. So they allowed then one IRB to cede oversight to the other, and they would use, like Jeanette and Tabria mentioned earlier, a memorandum of understanding process. So locally, we did this with one project in 2009. Locally, I would create a new protocol application in what's by that time finally was an electronic system, and would classify it as a project that was waiving oversight, and entitled it an MOU along with the study project. And I needed to upload for that the grant application, the full protocol, the approval form from Kaiser, and all of those supporting materials. And but it happened quite rapidly once it all got uploaded and submitted. In fact, I think that our IRB had probably communicated the approval directly to Kaiser before they had even communicated it to me. So I think it took about 2 or 3 weeks for this to occur. However, I don't believe that we could have been able to do that same process for a project that required full review. So again, that would be a minimal risk project where this would be most likely to happen. And our IRB has a similar agreement in place for another health system in the, based in the Portland area, Legacy Health. We haven't collaborated with them in this way yet, so I haven't had a chance to test that out, but I would imagine it's very similar. We also have several health systems that we work with as part of our membership. So with the Kaiser example, they were actually the ones who had received funding to conduct the research, and they were conducting a similar protocol in their setting. Then our PBRN was a subcontractor, and we were also conducting similar research. But we have several member practices that are part of health systems who have an IRB of record, but those practices aren't necessarily engaged in human subjects research themselves. So they, through an IRB authorization agreement, then can cede or become the relying IRB and provide oversight to us. So in those instances, again, the guilty culprit at the practice, the investigator who said, yes, I will participate, needs to sign a letter formally asking the IRB if you could cede oversight to OHSU. And then I also provide for that packet the protocol for the project and the approval memo from OHSU. And in theory, it's a relatively fast process. Then once they've reviewed and signed off on it, then the approval, the signed IAA comes back to me here, and then I would submit under a modification to add a study site. But it's never fast, actually, because it turns out that no matter when it seems that you get this letter signed and the packet off to that local IRB at one of these systems, you've always just missed the deadline somehow. And the IRBs here tend to meet only once a month, it seems. So you're waiting a lot of times, a few more weeks. And then after they've met, I've found that the responsibility is often back on me to follow up and get this letter back. So the process isn't seamless, but once you have the approval in place, then as Tabria was talking about, what's nice is you don't have to go back to the IRB with modifications or any changes that are happening. You only have to do one CRQ, which is locally here. So there are benefits. It just takes a little bit longer at startup. So I wanted to talk a little bit more about what an independent authorization agreement, what is required for that. This is from our OHSU, the OREO website, about what's required. And when they are going to accept authorization for another institution, what they expect, just like I think Jeanette had described too, that the IRBs do maintain an FWA, and of course you comply with the laws as outlined in the CFR. I think we all know every IRB may make small different determinations or interpretations of what that code says, but that in general each IRB is following that. And within OHSU we do have 4 IRBs, and any of those 4 could be the one, so it's not that there's one particular board that does these. And then just sort of setting out what the cycle is going to be. And then the relying institution must ensure compliance to the protocol and to the laws in the Code of Federal Regulations, safe conduct of research, that the personnel are properly trained, and that they're going to cooperate with our IRB. So onward we go with this waiver of oversight, and I think this is something we talk about all the time in my group, but it turns out across OHSU, not so much. Actually, I asked them to provide these numbers back to me they could easily calculate how many times they waive oversight to another institution. And in 2002 it was only 31 times, but they don't actually measure how often they accept oversight from another institution. And the sense from the IRB is, well, it doesn't actually happen that often, probably because a lot of the research that's happening here is at some of the care clinics, tertiary care clinics that we are affiliated with. So as I was reflecting on these different seeding opportunities, I realized that really the ones on the left really are for allowing us to conduct human subjects research. Our trained staff are going out and collecting human subjects research, but the institution itself actually isn't engaged in research. So those are the ones on the left with what used to be called the unaffiliated investigator agreement and also the independent authorization agreement. But really, I think what we're wanting to move toward is how can we set into place agreements between IRBs when both groups are actually engaged in the research, like the example that Tabria gave for the InStep project, which is an additional burden on each IRB, and they have to have more, be ready to agree to how each IRB is approving and understanding and interpreting these projects. So with that became the opportunity to apply for the P30s, and fortunately we were funded as MEDAL-ARC. And as we were responding and thinking about what MEDAL-ARC should really be poised to do, or any of the P30 awardees, is I think the goal has really been for groups to work together quickly and nimbly and to reduce some of that study startup time, which is always IRB. That's what study startup, I think IRB stands for study startup slow down or something like that. So we kind of imagined that our CTSAs, we are all affiliated except for one of our PBRNs, which is in Canada. The 5 of us in the United States are all affiliated with our CTSA. And I think we sort of envisioned as we were putting together our application that perhaps the CTSAs would make it a priority and would advocate for us for our IRBs to look at some sort of a formal process to make this happen more rapidly. And what we found is it was challenging to do that without having a particular project to respond to. So we were very fortunate for having the opportunity to test this out with InStep. But what would have been nice is if we could have worked out some of these agreements or some ideas before we got to the level of InStep, because poor Tabria probably, you couldn't quite hear the pain in her voice, but there was a lot of back and forth. There was a lot of coordinating. And the other thing was that I think we found through InStep is it's somewhat limited which practices we could go to, or we realized that moving forward, that it's not just our institution and your institution, it's also those IRBs that I've just been talking about that our member practices are affiliated with. So this is a work in progress, I think, and we're not really there yet, but we're hoping we can. So I went to talk to our IRB chair about this because I thought she would be really excited about this topic and would say, boy, oh boy, we've just been hoping for the day we could talk more about ceding oversight. But I actually got a very lukewarm response from her instead that was sort of like, well, why? Why is it that you think that this is better? So in general, I think it is, but I think maybe we're not quite set up yet to take full advantage of some of the benefits. But I wanted to sort of list some of the lessons learned from my perspective, one of which is no matter what, when you're doing an IRB review, it's just I don't think there really is a fast way to do it. However, I do see benefits with the ceding oversight, which I think both Tabria and Jeanette alluded to, which is that your modifications, your continuing reviews only need to be done in one place, and potentially for projects that do have interventions where you're monitoring adverse events, it could increase safety because a single IRB is able to look at any of those issues as they arise. But currently, I'm not sure that it actually accelerates the study startup. It feels like not yet. And as I was saying, I was surprised to find that I thought my IRB chair would really find this an exciting thing, but she didn't really. And it especially seems to be the case as you get into more complex study designs. If the FDA is involved, if you have an IND, it becomes far more complicated. So it's sort of, I think we still need to find the sweet spot. And as I was saying also, if one, kind of this whole thing of how are you going to recruit? Are you going to be able to recruit members from your membership practices that are going to be able to have an IRB that will agree to cede as well? So just to tell you the rest of the story from OREO, or OHSU's perspective, we are affiliated with the Portland VA Medical Center, and it's always been an incredibly painful process because many faculty are actually both at OHSU and at the VA, and it's a really great population. It's great to enroll subjects from both populations, so it's very common to want to get approval from both IRBs, and they are drastically different. Any of you who've had to play with VA IRBs in general, I've had to play with several over the years. That's just never easy. So our two institutions in 2014 did agree that they would put together what they're calling a joint submission agreement, so that it quickens the process to get approval from both, and you don't submit one protocol to Oreo and they say, great, you don't need to get consent, you're ready to go, and then you go to the VA and they say you need a 10-page consent, and you need, subjects to, you need the time and date stamp, you need a witness, all of those things. So they have created a separate board, IRB, that reviews these joint submissions together, and they assume that the project is going to look the same in both settings, so they don't make you change elements of your protocol. And they do still have separate tools. There are separate consent forms with VA-specific language for the VA consent forms, but the two IRBs have agreed that they will negotiate between the two of them what the burden should be to subjects, like how burdensome the consent process should be, for example. So they have fairly equivalent forms. So it feels like progress is being made, and I sense maybe part of why my chair was not so excited to talk about this was maybe this was sort of still fresh in her mind. So, so finally, as we've been continuing some discussions for a new Meadowlark project with some collaborators at Duke University, the question came up about IRB share. And we haven't been terribly familiar with it. We, again, asked this, our IRB chair about it, and she sort of said, yeah, I'm familiar with it. So I pulled this quote just straight from their website, and their website is linked there at the bottom. According to their statistics on their website, there are 45 institutions that are engaged with IRB share and 11 projects that are under review right now. But I was hoping we could open the polling question now so that people could respond about what their knowledge is or if they are a part of IRB share.
Great, yes, and the poll is now open. So does your institution use IRB share? The two options are yes, your institution participates in IRB share, and no, your institution does not participate in IRB share. So we'll just leave it open a little bit longer to make sure everyone has a chance to vote. And we'll go ahead and close the poll now, and we'll share the results, which you can see now. 18% said yes, their institution does participate in IRB share, and 78% said no.
Great. Well, thanks everyone for answering that, and I think it would be really valuable to hear more from the 18% who are a part of this, what their experience has been like, and if it's something that the rest of us should be exploring. So thank you very much.
Thank you very much, LeAnn. We are now going to open it up for some questions to Jeanette, Tabria, and LeAnn, and then we will move on to the final presentation. So a few questions have come in. I will read them, and at the same time you can see again how to submit a question. Kristen has put up the slide. So please go ahead. If you've got any other questions, please submit them. And if we can't get to your question now, we will try to get to it in the next Q&A session after the last presentation. So one of the first questions that came in was for Jeanette. The question was, for city certification requirements, how do you determine if someone is, quote, engaged in research? So Jeanette, I don't know if you want to take a minute or so to answer that question.
Well, so engaged in research, that would be that the person is obtaining the informed consent from the human subject. So let's go with an example that if there's an office that doesn't have its own IRB, and the University of Iowa is its oversight IRB now, and that nurse in that office is going to be doing the informed consents with the patient, then she is engaged in research. If she is going to be collecting their private information, their health information from the medical record, and giving it to, say, us for a research project, then she is engaged in research for that. And if they are participating in an intervention with the patient, if they are doing the intervention for the research project, then they're engaged in research.
Great, thank you for answering that question. Another question, this is a comment, there have been a couple of comments coming in from a participant who's actually very familiar with IRB share. So one question was, have any attendees experienced resistance to ceding review to other institutions? And just as a mention of IRB share, which, as LeAnn mentioned, is a type of another joint review reliance model that doesn't require the sites to fully cede all responsibilities for review to another institution. More information about IRB share was posted by this participant. We will see how to send that out to everybody who's on the webinar today. But another question that came in was about the IAAs. Are most IAAs that are being set up only between institutions or organizations that are within a small or close geographic proximity? So I don't know if
for the Iowa Research Network,
go ahead, yeah.
For the Iowa Research Network, we're all over the state, and so they can be a family physician office anywhere in the state, maybe 6, 7, 8 hours away that are doing authorization agreements.
And this is Tabria. I mean, we did it in Oregon, Iowa, and Wisconsin, and so I guess geographically they're kind of in the same area. But I'm sure that if we had taken, depending on the study design and what we were looking for, I'm sure we could have taken our protocols to the director of COMERB and asked him if we could then have the IAAs with another institution. And I don't think proximity is a deciding factor there.
Okay.
Yeah, this is LeAnn. I would agree with that too.
Great. Okay. Another question that's come in is, if institutions will not cede review, how can you make it easier to have multiple IRBs review a project? What process has worked for you in the past? So I know you mentioned IRB share. Are there any other processes that any of you would like to mention?
Well, this is LeAnn. I'll jump in first. I think I certainly have experienced it before, and I think in a lot of instances I haven't even necessarily tried. I've expected that we're going to need to do a separate IRB, and I think what can be very beneficial is to certainly provide all of the documentation from the IRB in making a determination for approval, like sometimes interpretations of minimal risk or interpretations around the burden of consent could be some of the places where you're going to have variability between IRBs. So as much as you can share your IRB's rationale for their interpretation and approval, it feels like you're more likely for the other IRB to agree to that interpretation and have the same one.
Okay, great, thanks. Another question came up about really the timeline for all these steps, and I know it varies, but the question is, there's the process for IRB approval could take, for example, 6 to 8 weeks or 3 to 4 weeks once the agreements or processes between the institutions have been set up. And I guess, what has been your experience in terms of timeline for getting all of those different steps set up?
So, Jeanette, when we did in-step with Colorado, it only took us about less than 2 months to get the 4 clinics that were participating. 2 of them had their own IRBs, to get their IRBs paperwork done, and to get Iowa's paperwork done and sent to COMERB, if I'm saying that right, Tabria. So it wasn't as long as it could have been. It was quite fast, but Colorado had already had the IRB approval, and that protocol we used then.
And this is Tabria. It probably would have been a little bit faster. I was on a really steep learning curve as I had never done this before, and so I feel like I ran into a couple of roadblocks on the way. But once we got everything through, as Jeanette said, it was a relatively quick process. I mean, we worked with COMERB, and they were there and they were helpful, and if any questions came up or if we ran into any snags or anything, they did their best to answer our questions, and it was able to then just, I think the longest part of the process was just general COMERB approval, which can take, as you had mentioned, 4 to 6 weeks or 6 to 8 weeks or however long your IRB takes.
But I think one of the key things that Tabria said and LeAnn emphasized later, and I'll say it again, when there is a modification that has to be done in the IRB, we don't have to do it at Iowa here. Just Tabria does it at Colorado, so it saves a tremendous amount of time for the 4 sites.
Good, thank you. A question is from somebody who is in the process of trying to set up a system of seeding. And this person is at an organization where they work with many different health centers, and all the centers have different methods for approving research projects and working with IRBs. So this is obviously a very general question, but I guess you sort of advise on kind of where to start in terms of setting up a seeding process.
I think you have to find your main IRB that's going to be the IRB oversight and start with them. But unfortunately, you have to go, I think you have to go through each site's IRB and their process of what they want you to do. What do you think, Tabria?
I would agree with that. I mean, I think it all depends on the components of the various projects, but I think it's important that you find the IRB that is going to be accepted, that the other IRBs could potentially see to, and then contact them or find their processes somewhere, because that was my problem, is I didn't do that first, and so it took longer. But just make sure that everybody's on the same page and all of the steps are outlined of what needs to be collected and the timeline it needs to be in, and then submit it that way. But I agree with Jeanette. I think you kind of have to vet each of the different IRB options to see which one works best.
And this is LeAnn. I think what I would add to that, I agree completely. I think one other piece is if you know you're going to be doing, these are a couple of institutions that routinely collaborate. What I've done with one of our health systems in the area is sort of sketched out different research activities. For example, we're doing a chart audit of your subjects, or we are surveying your clinicians, or we're coming in with a full-scale intervention, and tried to come up with in which of these is the other organization actually involved in human subjects research, and when are they not, and got the 2 IRB chairs and research integrity officers to speak with one another about what their expectations and agreements would be, so that they had a chance to kind of quiz one another and learn from one another, and then they would be able to advise me on particular projects which method I should use for seeding and which IRB should be the IRB of record.
Excellent. It's very helpful. I think one last question. It's about the waiving process, and you've talked a little bit about this, but the question is, under what conditions would an institute waive, and how would an IRB really approve of waiving their oversight to another IRB? And I think this probably depends on the site and the research study, but what has to be submitted over time as the study proceeds to IRB that has waived? So you've talked about how each individual IRB still has to be made aware of any adverse events, for example, or anything like that. But can you talk a little bit in general about what else has to continually be submitted to the IRB that has waived, that is ceded to another?
Well, this is LeAnn. I'll jump in first again. At the minimum, I maintain active personnel, the personnel who are involved from our institution. And sometimes, in my instance, the IRB will come to me when it's time for me to submit additional information. So I don't have to do a full annual continuing review, but they do have a shorter set of questions for projects where you do seed oversight, which are things like, it's sort of like what you might do for an exempt status project, where it's questions such as, are you still engaged in research? Is the protocol still the same? And then beyond that, I think, again, each individual IRB can really specify for you in which instances they will agree and which ones they won't. My understanding is there are definitions provided in the Code of Federal Regulations that each IRB can interpret individually. And your IRB can tell you, this is what we're going to require from you moving forward. Tabria, Jeanette, anything you guys want to add?
This is Tabria. The only thing that I would add to that is if there's any type of, like, a continuing review, as LeAnn said, or if there's an amendment because something has changed, that kind of stuff needs to be updated at both the sites. So once the approval letter comes back, once that has been approved, both sites need to have that approval letter. I need to keep that on record to make sure that everything is up to date and all materials that are being used are accurate and match what has currently been approved.
Okay, thank you very much. We've run out of time for the questions. There will be another opportunity to ask questions at the end. So we're now going to turn to Amanda Ross, and she's going to discuss the Collaborative Ohio Inquiry Network, or COIN, and the Ohio Reliant IRB system.
Thank you very much. Can you see my slides?
Not yet.
How about that?
Perfect. Yes, we can see your desktop and your slides. Great. Thank you.
Okay. So thank you very much for the introduction. I'm here to talk about the Collaborative Ohio Inquiry Network, or COIN, and the way that we have evolved into a CTSA-backed Reliant IRB system here in Ohio. Oh, wait, I don't let me move. Hold on one second. Okay. So COIN is a PBRN learning community that develops the capacity of PBRNs for research. We conduct high-impact practice-based research, and then we translate that research into practice and others' research into practice. We are also an AHRQ Center for Primary Care Practice-Based Research and Learning, funded in 2012. Ohio's CTSAs really provide a backbone for collaboration, and it was one of the ways that COIN actually came to be, is that we have 9 PBRNs within COIN, 8 of which are affiliated to Clinical and Translational Science Awards through 3 academic health centers. Northeast Ohio Medical University is not technically affiliated with the CTSA, and I will actually talk about that relationship when we talk about the Reliant IRB system. So I wanted to kind of start out with a history of where Cleveland's CTSA came to rely on each other, or the institutions relied on each other through interinstitutional authorization agreements, so that they were able to rely on each other and not have to repeat certain steps initially. The initial collaborating Cleveland institutions were University Hospitals Case Medical Center, Metro Health Medical Center, and Case Western Reserve University. Cleveland Clinic joined in 2005, but that was still a lot of paper-based work. The CTSA afforded us the opportunity to really facilitate and create infrastructure around something that was a little more robust when it came to relying on each other. Which brought us to the first caveat, which is that Case Western Reserve University does not have a biomedical IRB. We have a social IRB, so as a IRB of record, we cannot be relied upon. So what we have done, and we continue to do, is refer our investigators to our collaborating biomedical IRBs if they would like to implement a Reliant trial. And I am actually very excited about some news that I heard in the previous presentations, because here in Cleveland, our Veterans Administration has, we've been informed that they cannot participate in the Reliant system that we have in place here, and that they must independently review all of their projects additional to what the other institutions are reviewing. So I'm actually very excited to kind of take that back to my IRB chairs and see if we can make some headway here in Cleveland about that. So back in 2010, Metro Health Medical Center brought together each of the institutions, so the Cleveland Clinic, University Hospitals, Metro Health, and Case Western Reserve University, and said, we have this electronic IRB platform. Let's go ahead and just create a small space where we can all electronically share information. Each institution still used its own forms, consent forms, data use agreements, everything like that. And then each institution also performed full local reviews for context into approved data use agreements. So while they were sharing, they weren't necessarily relieving any of the burden. Everyone still had to input information at each site. It wasn't the silver bullet, I think, that as researchers we were looking for when they said they were going to put together a facilitated review process. They had this in place for about a year, and then in 2012, the participating IRBs within the state of Ohio, and that takes us back to the Ohio CTSAs being the backbone for collaboration in the state. Investigators and IRBs continue to look for collaborative opportunities, not just in their individual local areas, but in order to take advantage of the great research that was being implemented across the state. So they got together in 2012, 8 participating IRBs, the 4 that I've mentioned previously up in Cleveland, but then also Ohio State University Nationwide Children's Hospital, which is associated with Ohio State University, the University of Cincinnati, and Cincinnati Children's Medical Center, to create an agreement that would allow them to truly rely on the review of an IRB of record in order to facilitate collaboration across the Ohio CTSAs. And that brings us to version 2.0, which would be the Reliance agreement that they instituted across the 3 Ohio CTSAs. Again, they created a new space within this electronic IRB hub that was leveraged within the Metro Health System IRB. It's a Click Commerce product. What this agreement said was that they would no longer complete local reviews for context. There's a short 2-page application, electronic application, that's completed by the administrator for the IRB of record. They then upload all of the documents from the IRB of record, and they have created a system of review for relying on their individual IRBs for the data use agreements. The only decision that the relying IRBs make is whether or not to rely on the IRB of record. Everything else they have agreed to follow the review and recommendations of the IRB of record. So the goals and benefits they see here are that they created this hub and Reliant review process to see several overarching goals and benefits. They are looking to decrease the burden on investigators while maintaining the integrity of the IRB review, to streamline multi-center research, and grow collaborative research across Ohio, and to create a transparent and accessible electronic IRB process. Many IRBs have moved to electronic IRBs, but they don't necessarily speak to each other. I can tell you up here in Cleveland, of the 4 institutions, 2 are on one product, and then 2 others are on independent products. So it's by creating this hub, they have a place where everyone can upload information into a single space and not have to worry about the agreement of the programs speaking to each other. So key elements of the Reliant review as it has been orchestrated or created here in Ohio is that brief 2-page request form, a single IRB submission to the IRB of record, and this can be an initial submission or an amendment to a protocol that already has been approved within the IRB of record. The electronic hub, which is a very important element, which contains all of the study documents and reviews from the IRB of record and is facilitated by the IRB administrators. I will talk about that again, or I will continue to talk about that. One of the really great things about the system that I have found personally so far is that the IRB of record administrator and then the relying IRB administrators are really there to complete everything within the hub for you as the researcher and investigator. They have invested in the process, so you aren't trying to upload all of these things on your own. You send them the information they request of you, and they upload it into the system and make sure everything goes where it's supposed to go. And anything that's missing, they're very, it's a bi-directional relationship. It's fabulous. Once everything is in the electronic hub, there is an online review by all named IRBs with the ability to request additional site-specific information. Now, not necessarily changes, but if they have questions, they can ask them. One of the things that I think is really important when you're preparing a Reliant IRB, and I heard this, I think, in some of the other presentations as well, is that everyone's IRB is different. So when you're putting together a collaborative protocol, you are really want to make sure that as you are knowledgeable about your IRB and others are knowledgeable about their IRBs, that you're actually providing all of the information that you possibly can. It will increase the opportunity for your Reliant IRB to be approved, because the other relying IRBs will be more than happy to agree to allow the IRB of record to hold the record because you've provided all of the appropriate documentation and information. So you need a collaborative protocol. You need an IRB of record. Usually that is where the PI sits. The communication that exists between not only the research study staff at all of the institutions, but also the IRB staff at all of the institutions is very important. You need to get all of your study staff registered in the Metro Health IRB system so that when your staff goes to sign on and put the pertinent information where it needs to go, the IRB knows what you're talking about. So communication within your research group, in addition to the IRB departments at all of the institutions, is incredibly important. What the IRB of record does is they coordinate the submission of the protocol into the hub. And again, as I mentioned, this is the IRB of record administrator that is doing all of this for you. You submit it into the system and they upload it into the hub. Additionally, they add any consent documents, regulatory determinations, any pieces, parts that go with your protocol, they will get it into the hub. And then through the hub, they communicate with the relying IRBs electronically to confirm the collaboration. The role of the relying IRB is to agree to review the protocol. And again, you're going to increase your chances for a Reliant IRB approval if you've really taken into consideration the ins and outs of your IRB system when you're putting your collaborative project together. Because they will do an institutional requirements review to make sure that all of their major determinant points have been handled appropriately. But the only changes that are allowed to the protocol through the hub are to the consent forms. So they have the relying IRB has the opportunity to include the addition of language pertaining to persons to contact, or with questions or concerns and regarding subject injury language. Once they have reviewed, they have the ability to approve or disapprove the protocol call for local implementation. They issue an approval letter or a denial, and then they record the Reliant date approval at the organization. And again, this is all within the hub. And then if it's approved, they place the approved consent language on their template and stamp it and upload it into the hub. Continuing reviews and amendments, as discussed earlier, it's a lot easier to do it in one place. So the IRB of record handles the continuing reviews, the amendments, any changes in study staff. They are uploaded into the hub for review by everyone, and then everything is re-stamped. The relying IRBs can also go in and do independent updates to staff. So that does not have to go through, I apologize, that does not have to go through the IRB of record. So if I were working on a study with Ohio State, I would be able to update my individual staff without having to go all the way through to Ohio State. It would filter up rather than me having to start at Ohio State and come back. Right now, there are about 65 to 70 studies that exist within the Ohio Reliant IRB Review Hub, and it is reviewed and refined on a regular basis to attempt to increase the opportunities for streamlined collaboration. I will say that as far as COIN is concerned, we've had some bumps in attempting to work with IRBs that are more familiar and other IRBs that are less familiar with the Reliant IRB process. I think I'm a little spoiled up here in Cleveland because it originated through Metro Health Medical Center, which I have a lot of experience working with. So those at the other institutions, it is a steep learning curve, and the institutions are doing their best, but there's definitely some bumps. So as far as COIN and the Reliant IRB system, we have right now one specific study that we have put through the Reliant IRB system. Case Western Reserve University, Ohio State University, and the University of Cincinnati, and their participating healthcare institutions all have representation, so that went rather smoothly. However, Northeast Ohio Medical University is our fourth COIN partner, but they do not have representation. However, they have agreed to independently rely on the appropriate IRB of record for COIN projects on a case-by-case basis. So I would like to acknowledge my COIN partners at OSU, University of Cincinnati, and NeoMed, and Kathy Lowry, who is the director of the Reliant IRB review system at Metro Health. She is the visionary that is really behind what has gone on in Ohio, and if anyone is interested, I would be happy to put you in touch with her. That is about what I have, and if you wanted to launch the poll, that would be great.
Great. So we've just launched the poll, which is, would you be interested in accessing and expanding Reliant IRB in your local area? And if you are, we will connect you to Amanda Ross, our presenter. So we'll just give folks a bit more time to submit their vote in the poll. Okay, and it looks like a good percentage have voted, so we'll go ahead and close this poll now and show the results. Of about 38% of people are interested, so we will provide their names and contact information to Amanda.
Great. Thank you.
Thank you, Amanda. We will now open it up to some more questions. So if you have questions, if you can send them in. We're putting up again the slide that shows how to submit a question. One question that has come up, and Amanda, you may be able to address this more individually, but it might be helpful for others, is if you're in a situation where you work with multiple different entities, some of which have IRBs, others don't. And if you're not affiliated with an academic institution and don't have your own IRB, do you have recommendations for an entity where there are studies that do not include a principal investigator from an academic institution? And do you know of any funding or support that is available to help build an infrastructure to create an IRB within a PBRN setting?
This is Amanda. I don't actually know of any independent, I don't know of any funding at this time. Yeah. One of the things that we do within the PBRN shared resource is actually pair people with investigators from the academic health center so that there is a connection. So they end up being part of the study staff, but they are not necessarily the principal investigator. So right. we don't work a lot with, because we facilitate that pairing, we haven't run into that recently.
Okay, great.
Or would it be worthwhile to use a commercial IRB? I know that costs.
That could definitely be a possibility. Again, we haven't done that in our environment, but that's definitely a possibility.
Okay, if anybody else has questions, please send them in. I do have a couple questions that Rebecca Roper, who's the director at AHRQ of the PBRN initiative, had. I think we've addressed a number of these, but I just wanted to ask all the presenters if you wouldn't mind sharing any experiences that you've had working with multiple IRBs and some of the, what you tried and what didn't really work. So some lessons learned. I know several of you have already shared some of those, but if there are any others that would be helpful for others.
Well, I think right first up front you have to know if the office or agency that you're collaborating with has their own IRB. And it'd be helpful to know that before you submitted a grant. So to find out some of the basics about each office is good before you start your IRB process.
Mm-hmm.
And this is LeAnn. I think what I would add, we ran into this recently where there was a long-standing member practice who became bought out by a health system that had an IRB. And I think our mistake was assuming that the IRB was familiar with us and would have the same interpretations that other IRBs had about when they were or were not engaged in research activities. So I think what was really critical there was to sit down with the chair and have a very thorough discussion of different activities and get an understanding from them. Like has been pointed out many times before, every IRB can interpret things differently. So you will sometimes run into IRBs that will take the most strict definitions and will be see every potential research project as being a full-scale intervention and a full board review. So it was important to have those discussions and have an understanding of what their beliefs were.
This is Amanda. I would definitely echo that. And one of the things that we were able to do locally as well was to work on a project with our IRB to educate them about card studies specifically so that we could create an overarching protocol for card studies in our environment that simply required an amendment to a main protocol rather than reinventing the wheel every time we wanted to do a new card study. So going in and having those conversations will actually lead to opportunities that you hadn't even considered.
Thank you. That's very helpful. Okay, we do not have any other questions that have come in, so I think, Kristen, we can move to wrapping it up and talking about how to obtain CME credit for this webinar.
Great, thanks, Gabriella. So thank you to everyone for attending today's webinar. This live series activity, AHRQ Practice-Based Research Network Resource Center National Webinars, has been reviewed and is acceptable for credit by the American Academy of Family Physicians. This webinar has been approved for 1.25 elective CME credits. To obtain CME credit for your participation in this webinar, please first complete the online evaluation of this webinar, and you'll be prompted to do this when you leave the webinar. And then please email pbrn@abtassoc.com if you would like to request a copy of your CME Certificate of Participation. And please join us for our next PBRN webinar on September 30th on a new PBRN Research Good Practices report. We are also currently planning for and scheduling additional webinars on topics of interest. And if you would like to suggest a webinar topic, please send your feedback to pbrn@aptassoc.com. And in order to keep the discussion going on this topic, after participating in today's PBRN webinar, you will be automatically added to the IRB listserv hosted by the AHRQ PBRN Resource Center. And you may also join the main PBRN listserv, where general announcements of interest to PBRNs are posted regularly. If you would like to opt out of the IRB listserv, or if you would like to join the PBRN main listserv, please just send us an email at pbrn@abtassoc.com. Thank you again for attending today's webinar, and thanks so much to all of our presenters. This concludes today's webinar.